Hello, welcome again. Dr. Anthony Gonzalez here with Miami Community Health. We're here to talk to you about another important health topic. And I don't know if you know, but we are month of June. It's Scoliosis Awareness Month. Scoliosis, you may have heard of it, the S because the spine is a little curved. Well, we've brought our experts from Baptist Health, experts from the Miami Neuroscience Institute. And we brought Dr. Joby Whiting to talk to us about the spine, talk to us about scoliosis, and talk to us about some of the other issues that people have in their spine. So I want to welcome Joby.
Thanks, Tony. I really appreciate you having me here.
All righty. So first, why don't you tell our viewers and our listeners a little bit about yourself?
Sure. My name's Joby Whiting, and I am a spine surgeon over at Baptist Health. I've been at Baptist for about 8 years. I am currently the director of the Degenerative Spine Program, and I do a lot of outreach with the community in terms of spine health and things like that.
Yeah, that's what we're going to focus on today, the spine. We're going to talk about the spine. So let's first start with scoliosis. And I say, scoliosis is the spine is like an S, but tell our viewers, what is scoliosis?
Well, actually, you're really not far off.
Okay.
Scoliosis and the S kind of works out. Scoliosis is usually thought of as an abnormal curvature of the spine. And typically we're talking about lateral movement, but it can also actually be present in other planes as well.
All righty. And so is scoliosis something that people are born with or something that you acquire through the years?
Typically, it's acquired through the years. Most people get scoliosis right around puberty. But there's another group of patients who later in life, as they age, develop scoliosis as well.
All righty. And is there a cause for the scoliosis? Are you more predisposed as a man or a woman or in a profession or something?
For the idiopathic scoliosis that occurs near puberty, we don't really have a specific cause, and nobody knows exactly what's making that happen, which is a little bit frustrating. But it does seem to run in families, so we think there's probably some sort of genetic tendency to it.
All right. So how do we know if you have scoliosis? Do you know that? Do you pick that up in the doctor tells you on an examination, or will a viewer out there say, hey, I think I may have it because of something?
That can happen both ways, to be honest. Patients themselves notice things. They might notice that their shoulders are uneven or that their hips are uneven, or maybe a parent will notice that when they're watching their children. You might see a bump in the back. You might have a hard time standing up and walking straight. And there's also pain involved with scoliosis quite often. That doesn't give you a diagnosis. That might take you to the doctor. That might get the questions rolling. And then typically there's going to be some sort of imaging obtained that will really lead to the solid diagnosis of scoliosis. Usually starts with x-rays, but can involve things like CT or MRI as well.
Well, I mean, obviously anybody will have some back pain, I guess. So back pain is a big topic. But obviously you talked about the unequal shoulders and hips and so forth. Okay. And so as you age, will scoliosis get worse?
Scoliosis is progressive, so we do expect that it's going to worsen with age. And then the second type of scoliosis that occurs later in life is definitely a degenerative and progressive process as well.
All right. So you go to the doctor does an x-ray and he says, hey, you got scoliosis. What is the treatment? What is the first step? They put a brace on you to straighten you out?
Full body casting is kind of an old fashioned way of handling that. We've luckily come quite a ways with that. And so kids don't have to be worried that they're going to be walking around. Exactly. No, there are a lot of really excellent conservative ways to manage the symptoms of scoliosis. And there's a whole gamut of things that can be done, including certain types of physical therapy and working with physiatrists. Ultimately, sometimes surgery is involved as well.
Now, when you're talking about the, let's say, non-surgical therapy, let's say whether it be the physical therapy, the physiatry and so forth, are we trying to straighten out the spine again? Or are we trying to, because the spine does have a curvature and a normal curvature, right?
So ultimately, the goal of real treatment is going to be twofold. One would be to control symptoms, and the other would be to try to correct the balance of the normal curvature or balance of the spine. Most of the non-surgical options are meant to control symptoms, to control things like pain or difficulty walking or difficulty with mobility. And then when you start to get into things like surgery, you're of course trying to get symptom relief, but you're doing that while trying to restore a more normal curvature and balance of the spine.
All right. So why would somebody need surgery for scoliosis? I mean, why does it get that bad, or why is it so bad that you need surgery?
The number one reason would be pain. So when you have
Mm.
debilitating pain that's limiting your ability to do normal activities of life, then surgery can sometimes very successfully take care of that. Another thing is when you occasionally, and this is more rare, start to have actual neurologic deficit or problems where you can't use your nerves or your muscles appropriately because of this change in your curvature.
Wow. Okay, so let's talk a little bit about the surgery and the advances that we have. So what happens in surgery and what type of surgical procedures? And you don't have to, just kind of in general terms, what are you doing for these patients?
So the really general thing that we're trying to do is twofold. We're trying to restore a normal curvature to the spine, and we're trying to release pressure on nerves. And so there are many ways to do it. The surgeries tend to be pretty big, and they can sometimes be multiple approaches. So sometimes it's staged surgeries that happen at different times. Usually it will require some sort of instrumentation. And what we mean by that is we usually have to put some screws and rods in place to sort of hold the spine back into its normal position once we get it there.
All right. And these are long and big surgeries, right? And the recuperation and so forth are?
They used to be really, really long surgeries.
Okay.
And that's sort of, again, the old fashioned way of thinking about it. We have learned that trying to keep the surgery time shorter has resulted in much better outcomes and much lower complications. So it is now pretty routine to separate these surgeries that used to be really, really long, 12, 15 hours, into maybe two shorter, more manageable surgeries in the space of a week. And we do this ahead of time. This is planned out. Recovery is a big deal, and you have to be ready for it. And it takes a lot of work and rehab afterwards, but can be done very successfully.
Right. And so now you're talking about rods. And when you're talking about rods, putting rods in people's back, are these patients going to be able to be flexible again? Are you going to be limited after this type of surgery? And I know, life is not perfect. It's a balance, right? You're trying to alleviate the neurological deficits. You're trying to alleviate the pain. And, you can't also go out there and be playing basketball, maybe. I don't know. Tell us about what limitations patients are going to have.
Well, I'm glad you asked that, because I think that's something that people think about and get scared about quite a bit. The reality is there are going to be some limitations to your flexibility when we put screws and rods in the spine. Most of the time, patients don't even notice that because their own movement has been limited by the problem and the pain beforehand. So they don't typically notice a lot of loss of mobility, but it's there for sure. In terms of being able to have an active life, even people who have had scoliosis correction, even with large surgeries, can get back to active lives and exercise. You'd be surprised, actually.
Wow. Okay, great. And so in regard to what are the advances, what to kind of talk to our viewers about what are some of the advances that we have at the Neuroscience Institute at Baptist Health, and some of the things you guys are doing for these patients?
Sure. Two of the biggest things that have advanced in spine surgery in general and have been used specifically in scoliosis over the last several decades have been minimally invasive surgery, which allows us to approach, if not all, but some of the scoliosis surgeries with less disruption, smaller incisions, less disruption of the soft tissue like the muscles. This makes less blood loss, and importantly, it makes the recovery a lot easier. There's less pain. It's easier to get mobilized early on. And so this has made a really big difference. And we have all of the latest minimally invasive options here at Baptist. Another really big thing has been image-guided surgery. And so that allows us to use CAT scan, basically images that we get during the surgery of the patient, and use them in real time to guide where we're placing screws, where we're placing rods, how we're decompressing and changing the curvature of the spine. And
Wow.
so those are really big developments for us.
All right. So we've learned a little bit about scoliosis. We know it's an abnormal curvature of the spine. We know that, it can be very mild and may not need any treatment. And the treatment can initially be, physical therapy, physiotherapy, and so forth. And then, of course, we learned about some of the surgery. Now, if somebody has mild scoliosis, they know they have it. When should they be looking for treatment, and when should they be looking for care and evaluation by an expert like people from your team?
Honestly, I don't think it's ever too early to start with the initial evaluation, probably not with a surgical team. And the good thing about what we have going on at Baptist Health in our spine center is that we have a whole fleet of physiatrists who evaluate and then manage these patients who have milder, earlier on symptoms, and they help them to learn good spine hygiene and to try to maybe even stop the progression from getting to the point of needing surgery. And when they do need surgery, then they'll direct them to us. I don't think it's ever too early to be seen by somebody like a physiatrist if you know or suspect that you're having scoliosis problems, because then they can get you into a spine hygiene program that can try to sort of limit your progression of symptoms.
Now, if I don't want to get care and I ignore it, can it get so bad that I can become paralyzed from scoliosis?
That would be a very, very rare thing. Certainly, if your scoliosis progresses to the point where you're having narrowing or stenosis that's pinching on nerves, and you can start to have problems where the nerves don't work well. The most extreme version of that would be paralysis. It's not something that happens frequently.
So first, you're probably going to start noticing weakness in a limb or an extremity and so forth, right?
Numbness, stuff like that. Numbness, weakness, and pain. Those are the things you'll notice first. All
right. So we've learned about scoliosis. You know that it's an abnormal curvature of the spine. Getting evaluations and care early on is going to help. That spine hygiene. I've heard a lot about different hygienes. I've never heard about spine hygiene. So there's a different type of hygiene. It's not really washing your spine. No. It looks like it's not like cleaning your spine or cleaning your back, but it's appropriate care of your back and getting the appropriate treatment early on, as opposed to waiting for the need for surgery. And we've learned about some of the advances. So before we move on, let's talk a little bit more about this other topic that we want to talk about, which is degenerative disc disease. And so explain to our viewers in simple terms, that's a very more complex term and that's a medical term. What does that mean, degenerative disc disease?
Yeah, so that is a little bit of a scary term just because it has the word disease in it. But basically, this is a medical term for regular age-related, wear and tear-related changes and degeneration or loss of some sort of youth or height to a disc segment in the spine.
So why don't we go back one step and let's tell our viewers about the spine and the discs.
Sure.
And so they understand how that works and why the discs are important.
So the way that your spine works, and we've all seen these pictures of the spine, you have bones, and we call those vertebra. And then in between each vertebra is a little pad. And this is a shock absorber, really. And that's what we call the discs. So those are intervertebral discs. So they're in between those bones in the vertebra. With time, just like all of the other tissue in our bodies, those start to age and they lose hydration, they lose elasticity, they kind of lose their oomph in their ability to be a shock absorber. And for some people, sometimes that can lead to symptoms and problems.
So what happens in degenerative disc disease? In this disease where the discs go bad, they just flatten out and now you have the bone on bone?
That's a really extreme version of it, and it can certainly get to that. But yes, over time, and we've all heard this story about how grandma used to be 2 inches taller or whatever, and as we age, we sort of lose height. That's actually kind of a joke, but not really. We do lose height as we age, and it's because just little millimeter by little millimeter, our discs are starting to lose height. When that happens, it sometimes doesn't mean anything at all. It just is something that might show up on an MRI. But sometimes what it does is it starts to compress or pinch the areas where the nerves are. And when that happens, it can really lead to a lot of pain.
All right. So we learned about this disease. How common is this? How are we going to, is this like everybody has this?
This is pretty much like everybody has this. I mean, it's as common as
I'm not going to get this.
Wrinkles.
Am I going to get this? Oh my God.
No, everybody except you.
Right.
So we like to say that it it kind of mirrors your aging, right? So in your 40s, about 40% of people have it. By the time you get to your 80s, 80% or more of people have some evidence of it.
So you have it like maybe radiologically, but are you gonna have it physically or symptomatically? Are you gonna have it like at 80% of 80-year-olds will have symptoms of degenerative disc disease?
So it's a little bit of both. For sure, at least 80%, and I'd say even close to 100% of people in their 80s are going to have some sort of thing radiographically. So what I mean by that is if you get an X-ray or a CAT scan because you were in a car accident, the radiologist is going to notice that you've got some loss of disc height. You've got some stuff that can be called degenerative disc disease. However, that doesn't mean you're symptomatic. That may be news to you. On the other hand, it also is very common for it to become symptomatic. So in your lifetime, at least 85% of Americans will have at least one episode of pain that's relatable to that. The really great news is that for most of us, these are self-limited experiences. You've remembered, you took a long trip on the plane and then the back of your leg felt like you had sciatica or something like that. These are the types of things that come and go that are related with it, but most of the time they don't become permanent.
All right. So I was going to ask you that. What are the symptoms? What are people going to feel if they have that shortening of their disc height and they're losing their disc? What are common symptoms? Are you going to have back pain?
Back pain comes and goes, and that can be related to the loss of disc height. But the thing that usually brings people to me or to one of my physiatry partners is what they call sciatica, what I call radiculopathy, but basically nerve root pain. So pain radiating or moving down the leg or the arm, a lot of times burning and sensation, sometimes with some tingling, numbness, that sort of thing. And that's because in your spine, where you're losing your height, you're starting to pinch the nerve, and a pinched nerve bothers you by going down the leg.
All right. So if you have radiating pain down your arms, and I remember this because my sister-in-law, who at that time was living in Puerto Rico, came here and ended up having, I didn't realize how bad it could be in the arms as well.
Yeah. Yeah.
That unbearable pain in the arms.
Yeah. I like to compare it to a toothache. Because people really underestimate how badly nerve pain can hurt, but this is what nerves do. Nerves, they report on sensation, and they're very, very good at letting you know that there's pain going on. And it can be devastating and debilitating sometimes.
All right. So if you're a viewer or listener and you're having this radiating pain down the arm, down the leg, and it's happening on occasion, what type of help should you be seeking?
So if this is just happening on occasion and it's really just some pain and you can sort of tell, okay, I know if I'm going to be in the car for 8 hours, I'm going to have this, that sort of thing, even just NSAIDs and things like that probably are going to be all you need, but I would bring it up with your primary care physician. They're very, very good at recognizing this, and they're likely to tell you maybe do some core strength exercising, maybe stretch, maybe stop and walk for a little bit here and there. There are little tricks that you can do to try to keep this from happening, and mostly take anti-inflammatories.
So that's what I heard you say. So you're gonna recommend for people that are having it occasionally, see their primary doctor.
Yep.
Take some of the Motrins and the Advils and the ibuprofens, and then some core exercises.
Correct.
So core, you're not only trying to strengthen your back, you're trying to strengthen the abs as well, right?
Honestly, core is more about abs than anything else, but it's for the benefit of the back. And so it's really Pilates style core strengthening that takes the pressure off your back. And you can kind of even think about it. If you're standing in line for a really, really long time, you start to have a little ache in your low back. What do? You contract your abs and you stand up a little bit taller, and it takes that pain away from the back. Every time we build the strength in our core, in our abs, we're unloading the back. And so it's really a great way to do that. That's spine hygiene.
That's more spine hygiene.
Yeah.
So I've also heard that if you put your foot up on something, it also releases your back when you're standing. Is that true?
So if you put your foot up on something, you may be opening or closing that space where your nerve is exiting. So depending on what your anatomy is, just doing that may shift something off that nerve. So if you're starting to have that pain going down in your butt or going down into your leg or something like that, it might take that off.
All right. So when you've gone to your primary doctor, you get your usual checkup, that you tell the doctor this is occurring sporadically and you're managing it with, exercise and anti-inflammatories. When are you seeking real care, and when should I be worried?
So, when you're seeking real care, would be if these symptoms are going on for more than 1 to 2 weeks and are not getting relieved with the things that we were talking about, like some Advil here and there, or maybe some physical therapy, or maybe resting or changing your activities, that sort of thing. So, if you're having persistent pain that's not responding to those things, you definitely need to see your doctor. If you're starting to have numbness, particularly numbness that's not going away in your arm, in your leg, in your feet, in your hands, go see your doctor. Definitely, if you have weakness where you're dropping things or your foot doesn't pick up the way that it should, or you're tripping, things like that, where you're having weakness in some part of your body, that's a sign it's time to see your doctor. And very rarely you can have something like problems with your bowel or your bladder where you have incontinence. And that's something that I would just go straight to the emergency room for. That almost never happens, but if it does, you should pay attention to it.
All right. And so you see your doctor, maybe the primary doctor is a little limited in understanding. Is there medical therapy for this? I mean, are there medications that are going to help with the disc, that the disc is small and now compressing your nerves?
So we don't have a way to reverse aging yet. And so no,
I thought
we're
Botox reverses
well,
aging.
Botox reverses what aging looks like. So unfortunately, we don't have Botox for your disc yet.
Okay.
So we're not actually going to be able to increase that disc height. But what
Okay.
we can do, there's a whole plethora of medications, and some are good for some people, some are good for others, that can address the symptoms. There are also activities that can address the symptoms and the likelihood that those symptoms might come back or not come back. And the types of physicians who are very good at this are, again, physiatrists. It's sort of the same. It overlaps with all spine and scoli as well. So getting tied into somewhere like the spine center, where you have people who that's what they do. They deal with spine related symptoms in a non-surgical way. That's a really good place to start.
Now, of course, some people are going to end up with you.
Yes.
Who are those people that end up with a neurosurgeon like you?
So probably about 15% of people who have persistent degenerative disc disease problems wind up getting surgery.
Okay.
I'd say there's significantly more than that who wind up coming to see me and being evaluated by me. Just because you get sent to a neurosurgeon does not mean you're going to need to have surgery. I probably have about a 15% rate of the people that I evaluate who actually do need surgery the first time I see them. So don't panic if your doctor is sending you to a neurosurgeon. It's a very scary word, but we're nice, we're friendly. And in addition to that, it doesn't mean you have to have surgery. It just means someone like me needs to evaluate to make sure that it's still safe for you to get treatment without surgery, or to say, hey, here's a surgical option. Maybe this would be better for you.
All right. So I'm one of the 15% of people that need surgery.
Yes.
What I want to know is who donates their disc to put inside of me so that I can get a new disc.
Yeah, we don't have that yet, but we do have artificial
All right. So
discs.
just
Yes.
tell us, so
Yes.
how do you fix the problem? And one of the things I was a little concerned about what you said is that you're getting medical therapy for the symptoms, but there's still compression on a nerve, right? Is that concerning?
Well, it's concerning if that compression on the nerve is showing that the nerve is starting to have problems, right? So it's really not concerning if just on the MRI or on the CAT scan you see narrowing there, because sometimes your nerve just gets used to it and
Okay.
it sort of adjusts when it happens very chronically and slowly. The concerning thing is, again, if you start having persistent numbness or tingling or weakness. Those are the really two most concerning issues with that.
All right. So surgery, if you need surgery, what are we doing now at Baptist Health, that you're at the Institute for these type of problems?
So we have a lot of different options, and everybody's surgery is individually based on them, right? So there are things that are as straightforward and small as a minimally invasive lumbar discectomy. That's a surgery I do a lot of. It's about half an hour. You go home the same day, and usually when you wake up, that bad sciatica is gone.
So that means you're taking out the disc.
I'm taking out just the piece of disc that has come out and is pushing on the nerve root.
Okay.
We really try to minimize the changes to the spine. Unlike scoliosis, with degenerative disc disease, we're usually trying to minimize the change that we make to the structure of the spine with surgery. We're really just trying to decompress the nerve root and get the pressure off the nerve root for the pain.
So we talked about that option. What other options exist?
There are other bigger options where you sometimes need to fuse. If you have to take off enough bone and ligaments and part of the structure of the spine that keeps you stable to decompress the nerve root, to get rid of those symptoms and to make the patient safe, then sometimes you have to add a much more limited version of those fusions with just a couple screws, just some short little rods, and maybe a graft in between the two discs.
Wow. So it's either and then are there any other options?
Yeah, we do sometimes do artificial discs as well. That happens a little more in the neck than it does in the lumbar spine, but that's also an option. The issue is that spine problems are very, very individualized, and we sort of have to pick what your MRI looks like, what your pain pattern looks like, and what your exam looks like, and kind of make a surgical plan specifically for you.
Yeah, and I always forget that, this also occurs in the neck.
Yeah.
And in my mind, I'm just thinking about the back, I guess the lower back, and the legs, but it also occurs in the neck. Is it more dangerous in the neck?
It does also occur in the neck, and it is more dangerous in the neck. It's, again, nothing to panic about because we have really effective, really safe ways to treat this. But the difference between the neck and the low back is that in the neck, you have your spinal cord that can potentially be involved. In the low back, your spinal cord has already ended, and now we're dealing with spinal nerves, which can also be very significant, but spinal cord injury is much more devastating and has bigger potential problems.
Wow. Well, so we've learned about scoliosis. We've learned about this degenerative disc disease, which is, the discs, losing their height. And really what surprised me today was all this about spine hygiene. And we know, because we're physicians, and the best medicine is preventative medicine, right? When you don't need to see me or you, that's great because you don't need surgery since we're surgeons. So what are the kind of the parting thoughts you can give our viewers about great spine hygiene and staying out of your office?
Absolutely. So the way to avoid someone like me is to not smoke. Smoking increases the rate at which your spine degenerates significantly. Maintain a reasonable weight, right? Because you don't want to put extra work on your back, because if that over years really has its toll. Core strength exercises, very, very important to maintain a good core strength. And good nutrition. You want to make sure, and especially for the women out there, as we are all unfortunately aging, we want to make sure that we fight osteoporosis because that really can help.
Wow. Well, another great show, another great good information. At Baptist Health, Joby Whiting and her colleagues at the Neuroscience Institute are available for all your neuroscience needs, whether it be from the brain to the spine. We focused on two topics today. For Scoliosis Awareness Month, we talked about scoliosis and what it is and what the therapies could be. And then we talked about the disc disease, the problems with the discs, and how we will all have degeneration of our discs. And so, again, preventative medicine is the best, eating well, exercising, no smoking, limited, obviously alcohol consumption and so forth. Those are the key that we've heard over and over on this show. So, Joby, thank you.
Hey, Tony, thanks for having me. I really appreciate it. And thanks to Miami Community News for having me as well.
All righty. Well, great. Thank you to our viewers. And once again, Dr. Anthony Gonzalez.